So now we'll be formally starting the session. Dr. Muneeb Karim is a distinguished radiation oncologist with a robust academic and clinical background. He's a graduate from Dow Medical College and completed his FCPS in radiation oncology at the Aachen University. Here, he also served as an instructor and later served as a senior instructor at the Shaukat Khanum Memorial Cancer Hospital and Research Center. Currently, Dr. Karim is a clinical and research fellow at McGill University, with his areas of expertise including neuroradiation oncology, stereotactic, and genitourinary oncology. Dr. Karim's research portfolio reflects his dedication and advancing through the field of radiation oncology, with over 100 citations to his credit. His work spans clinical approaches that align with his clinical interests, demonstrating his commitment to evidence based practice and innovation in cancer care. Our esteemed guest speaker will be taking us through the principles of liver SBRT for both the primary and metastatic lesion. This session will be divided into two parts. Today, we'll be covering the literature and the indication of SBRT in liver part, and then we'll subsequently be having part two, in which we'll be covering the later portion of the session. So I'll request Dr. Muneeb to please be on board, and thank you so much for contributing to this session today and for sharing your knowledge and helping us through the recent advances in liver SBRT.
Assalamu alaikum. Thank you for your kind introduction. Let me share my screen. Do you see my screen now?
Yes, Dr. Muneeb.
Yes.
Okay. So, Assalamu alaikum, everyone. So, as it was mentioned that today we will be covering this topic into two sessions because it's a huge topic, and I will try to summarize according to the learning objectives sent to me. So there were more than 50 learning objectives that were sent to me by email. So I have divided those learning objectives into two main headings. One is related to the literature, and the other one is related to the practical aspects that of radiation therapy, that's SBRT. So before going towards the learning objectives, regarding the introduction of the SBRT, everyone is must be familiar with that, but just go through the brief overview of SBRT. That the first term SBRT was initially introduced in early 1990s, and usually the SBRT is a technique extrapolated from stereotactic radiosurgery, and it is a very high dose per fraction of radiation compared to conventional, and delivered in a limited number of fractions, usually up to 5 or 6, and with a steep dose follow from target to non-target areas with high heterogeneity that is desired, not homogeneous, heterogeneous dose within the target area. So, as I mentioned, it was initially started in 1991, investigated in the liver and the lung, and later on it was developed in Japan as well, or in early 90s, and later on in Europe, and first time in 2001, the clinical results were published in lung cancer, and followed by Timmerman in 2003. So the name SBRT, stereotactic body radiotherapy, was introduced by Dr. Timmerman in 2002, and also the word was used as stereotactic ablative radiosurgery for this treatment. But because the other techniques like RFA, these techniques were known as ablative techniques. So this term is still used, but now the most common word among radiation oncology colleagues is SBRT. So why SBRT? It is a high, it's ablative dose, more than 100 or more than that even. Cost effective in terms of number of fractions. Patient does not have to come for a longer period of time, non-invasive, and in some cases, it is alternative to surgery. And it has been shown good results uh, in early prostate cancer, for example, early non-small cell lung cancer, even SBRT in renal cell carcinoma, spine, hepatocellular carcinoma, and oligometastasis. So today we will be discussing about the liver, so we can divide this into two main components. It could be the liver cancer could be the primary hepatocellular carcinoma. The other is the metastatic disease. So we will be covering learning objectives related to HCC first, and later on related to liver metastasis. Before going into the detail, we should know about the anatomy of the liver. So it is divided into broadly two main areas. One is the right hemiliver, and all this data is derived from the surgical series. So right hemiliver, left liver, and the term which is used, right hepatectomy and left hepatectomy, corresponds to the number of the areas that are resected. So this one is the left side, left hemiliver, 2, 3, 4, and this one is the right side. Sorry. So these liver areas are divided into segments based on their blood supply and their bile drainage. If you look into the number of the sessions, again, I used to have problem to remember these, but if you look at it, it is clockwise numbering of the liver segment. You could look at it 2, 3, 4, 5, 6, 7, 8. Some two people remember with the help of the punch finger, but it's clockwise. So why it is important? Because while marking the tumor, we should know that in which area, when we are reviewing the liver's CT scan or MRI, the diagnostic modality, we should know that in which area the lesion has been reported. Also, the anatomy is also very important when we are following up the patients, because sometimes patients present with multiple metastases, and we have to take care of which lesion was treated, and they have been treated with RFA, TACE. So if you do not know the liver segments, you will not be able to identify the lesions and mark them. So it is very crucial and important to learn this. Uh, there's a very good website I would like to show you. Wait. Yeah. Do you see my screen now?
Yes, Dr. Muneeb.
Okay. So this website is very good. I always look at this website. It is a radiology assistant, and you can look into the various sites of the body. And in terms of liver, so they have given all the segmentations of the liver. It's very easy, and they have demarcated the liver segment based on the CT scan. So whenever you are looking into the MRI of the diagnostic images, you can go there and see according to this. And they also have images related to the liver, and they have shown segments of the liver as per the MRI. Okay. So I always look into this website and refresh my anatomy. Yes. Okay, continuing with the presentation. So I'm not going into further details of the anatomy, but the number of the segment is very important for the radiation oncologist to know the detailed anatomy of the liver lesions, and it's very crucial for marking the SBRT part. Okay, so just to remind ourselves with the Child-Pugh score, because this score is commonly used to see the liver function of the patient, and it is based on the five parameters, that is ascites, level of the bilirubin, albumin, INR and PTT, and encephalopathy. So usually, if a patient has a Child-Pugh A, it is known as a well-compensated disease, and early Child-Pugh B is still with significant functional compromise, but still it's considered as better. But Child-Pugh C is known as decompensated liver disease, and usually these patients have a bad prognostic survival status based on their liver function state. So most of the we should know about it, because when we see a patient, we always look into these parameters to decide about the patient and the before taking the decision of radiation therapy. In terms of staging, not positive is always stage 4, and in term if we simplify this, it is 2 centimeter up to 2 centimeter without vascular invasion, T1, and T2 is more than 2 centimeter with vascular invasion. So vascular invasion is an important factor. We will discuss about this parameter later on. So key points about the HCC is the causative agent is or the hepatitis B and C viral infections, and liver is also a common site of metastasis. And for the HCC, it could also go to the abdominal lymph nodes, peritoneum, bones, and lungs. And about 60 to 80% of the patients of hepatocellular carcinoma, they have underlying cirrhosis. And usually it is diagnosed on the imaging studies without tissue biopsy. Okay. So now, what is our first learning objective? That identify most suitable patients with HCC for SBRT and what are the contraindications? What is the evidence of use of SBRT? And the role of SBRT in the definitive or non-transplant setting for HCC or palliative settings for primary liver tumors. So I will be discussing these points in the coming slides. So Barcelona Clinic liver cancer treatment for hepatocellular carcinoma, these guidelines were published in 2022. This is the most updated ones. And this is the most widely validated staging system and treatment strategy. But there is again variety and discrepancies in this BCLC treatment strategy, because sometimes if you look at it the very early stage and they have based on the performance status and the size criteria, but still people argue that those patients, even who are good with good performance status and are very 4 to 5 centimeter.
पढ़ने ना देना ऐसी
So the problem with this BCLC clinical liver cancer guideline is that still there is no mention of radiation therapy in these guidelines. You could look at that in these early two boxes, which is the early stage, and these are the patients who are usually candidate for surgery. We will be talking about this stage that will be intermediate stage or slightly early stage, advanced stage, because these are the patients of the who fall into this category, who are the candidate for the local regional therapy. So I hope that because of the availability of the further evidence of SBRT, they will be including the role of radiation therapy, optional radiation therapy in their guideline. Again, even among the surgeon, still there is discrepancy upon the liver status, and also in terms of child progress score. Also, we discussed about it. The child progress score represents the status of the liver function in a patient. But the problem is that it is not widely validated in the patient with the HCC, that how it's going to respond. So again, we will these are the patients, just to let you know that we will be discussing about the role of SBRT, and the data is emerging for these patients. If we look into the guidelines, further guidelines, like BCLC I have shown you, Japan, Asia Pacific, initially there was no radiotherapy recommendation in their guidelines. In ESMO and Korean guidelines, radiotherapy is still an option, an alternative to the local regional therapies. Astro also endorsed as an option for those patients who are unfit for the surgery and ablation, and in the case of recurrence. UK published their guidelines as BRT as an alternative to the lesions which are multiple with different criteria. And NCCN also mentioned SBRT as an option for the unresectable, inoperable patient. So in the absence of the guidelines, so do we still consider SBRT in practice? So the answer is yes, it is used. And actually the availability, efficacy, and safety of the specific therapeutic approaches, especially the non-surgical liver-directed therapies, tend to vary based upon the available expertise. It depends upon the available expertise in the hospital, in the country. So the first learning point for me and for everyone is the role of multidisciplinary team in optimizing outcomes for HCC patients receiving SBRT. So this is the main learning point for all of us, because there is a wide variety of treatments for hepatocellular carcinoma, and they are offered by different specialties like surgery, transplant, hepatology, interventional radiology, radiation oncology, medical oncology. So multidisciplinary evaluation and planning and management is frequently coordinated by the hepatologist, and this can improve the patient outcomes. So it's highly dependent upon the skill, expertise, and comfort level of the treating physician. That's why the role of MDT team is very important, although in all the tumor types, but specifically in this, because the best treatment of patients with SCC relies on the robust multidisciplinary group expertise. It's very crucial. As far as the definitive treatment is concerned, so surgery, resection, or transplant is the standard curative treatment modality for hepatocellular carcinoma. What is the problem? The problem is that the majority of patients are not ideal candidates for surgery, especially in the lower and middle income countries. And the non-surgical treatment modalities, they have been used for localized disease and for early and local advanced SCC. The literature is full of that. So what are the non-surgical treatment for local advanced disease? One is ablation. This could be frequency ablation, cryoablation, microwave ablation. There are some arterial directed therapies like TACE, transarterial chemoembolization, or radioembolization. The data is emerging. And then radiation therapy. So these are all the non-surgical treatment for the locally advanced disease. And among them, so RFA and TACE form the mainstay of the liver-directed therapies, and the literature is full of that. And in the RF has also been compared with the surgery as well. And the result of, again, it depends upon the local expertise. Up to 85% of the complete response have been reported, especially in particular for the tumors of less than 2 centimeter in size. So they are comparable. But again, surgery is better in terms of overall survival, progression-free survival. The data indicates that. So the non-surgical techniques, RFA, is thermal ablation of the lesion. It is usually curative for 3 centimeter of the lesion, and it normal tissue around to cover all the tumor adequately. What are the contraindication of the RFA? All the lesions who are more than 5 centimeter and who are near the large blood vessels, usually it is taken as a contraindication for the RFA. Because the problem is that when the lesion is near the large blood vessel, major vessel in close proximity to the tumor can absorb heat. That is known as heat sink effect. So this can reduce the effectiveness of RFA in those lesions. So most commonly used has been proven in multiple randomized trials and oncological outcomes comparable to surgery. So we know this. And this is done by the interventional radiologist. Regarding radiation therapy, why radiotherapy adaptation is slow in hepatocellular carcinoma? The problem is the patient often presents with the locally advanced disease and sometimes invading the large vessels. And the problem, if the tumor invades the large vessels, so the other this is an adverse prognostic factor because it when the thrombus is present in the vein, it could increase the portal vein pressure, and this could lead to SITs, and this shows the aggressiveness of the tumor. So other local therapy have a limited role in those circumstances. So radiotherapy could be an excellent treatment in this situation. The problem is with radiation is that because of the although HCC is now known as it responds to radiotherapy very well. The problem is the normal tissue of the liver, normal hepatocytes. They are quite radiosensitive. And in the past, we did not have the precise technology. Now, with the advent of new therapeutic machines, we can deliver precise radiation therapy. So that's why the role of SBRT is coming up now. The main problem with radiation therapy is the side effect of the radiation-induced liver disease. Liver is a parallel organ, and as I mentioned, that hepatocytes are known to be radiosensitive. These cells release various substances that promote the liver fibrosis. So previously, when we used to treat with the 3D CRT and 2D CRT, so they were not very conformal, like with the advent of IMRT, VMAT, and other techniques which are quite conformal. So we are able to spare the normal liver very well. So this is the main side effect of radiation therapy that could appear in the patients, which is a clinical syndrome, and it can occur from 2 weeks after radiation up to 4 months after radiation therapy. It could be of two types: veno-occlusive disease, which could present with raised liver functions, and the non-classic, but the reason is unknown, and the patient present raised transaminases. And the important point is that we will be discussing about this when we will discuss about the SBRT prescription and selection of the patient. The volume of the liver is more important rather than the number of metastases. It's not a number game anymore. That one lesion, two lesion, three lesions. We have to look into the volume of the normal liver that we could spare. That's a very critical part. Even in the brain now, we are thinking we decide according not as per the number of metastases, brain metastases. We decide according to the volume occupied by the number of brain metastases and normal brain volume we could spare. So in this scenario, we have to look into the normal liver, which we could spare with radiation. Okay. So the other learning objective is, okay, now we can offer SBRT. So what are the clinical outcomes? What are the local control rates? What are the survivable outcomes, and what are the toxicity profiles? Again, it's an emerging modality. Up to, if the lesion is less than 5 centimeter, we are talking about more than 90% local control rate as per the reported literature. As the lesion size increases, the local control rate could drop to between 70 to 80%. Again, we don't have the randomized control data. Recently, there was a trial published. I will be discussing briefly that trial. Those lesions which are near to the major vessel, which is the contraindication of the RFA, and with a larger tumor size, more than 3 centimeter. So these difficult for ablation RFA. So these patients we could select for SBRT, and SBRT is a very effective treatment in terms of those local control and to stop the to provide a very good PFS. There are many phase 1, phase 2 studies, retrospective studies, and all of the studies have reported the 2-year local control rate up from 84 to 100%, and overall survival rate at 2 years between 34 to 83%. The important point keep in mind is that the good results are related to administration of a really ablative dose. Usually we talk about the 100 gray BD, but at least in some of the retrospective study, we have to consider at least 80 grain BD. The usual fractionation is 50 grain 5 fractions and 48 grain 3 fractions. Both these radiotherapy prescriptions have a BD more than 100. So what about the toxicities? Just I mentioned that our radiation-induced liver disease and other parameters. So we are giving a very high dose of radiation, like 48 gray in 3 sessions, 16 gray per session, or 10 gray per session if you are prescribing 50 gray in 5 sessions. So the grade 3 toxicities can vary from 0 to 36%. Again, it depends upon the underlying liver disease, underlying function of the liver, and whether patient has a carrier of hepatitis B and other infection, and the severity of cirrhosis. So it can vary up from 0% to 36%. Even for the radiation-induced liver disease, if we plan, we will discuss about it. But if we consider all the parameters in mind, the incidence rate is less than 5%. So this was the systematic review and meta-analysis that was published because we don't have the randomized control data. So this systematic review include the studies which were observational, and they try to find what the evidence we have. So they defined the early HCC as up to 5 centimeter of the maximum diameter, or multiple nodules up to 3 centimeter, and at least child POG A or B, and which patient RFA or liver transplantation is feasible. Okay. So this is the diagram. They showed that the literature related to the SBRT. We can see that there is a peak after 2015, and again, if we publish this, if we look into the data again, so it will be going above, because in the recent years, data and publications related to SBRT are coming frequently now. So they reported the median overall survival as per this systematic review meta-analysis up to in 1 year up more than 70%, and local control rate up 86% at 1 year. And grade 3 toxicities, GI and hepatic toxicity, less than 5%. And the child POC class was associated with significant, showed significant correlation with the hepatic toxicity and also the tumor size. Okay, what is the so the next learning objective question is compare SBRT related toxicities to those of other therapies such as thermal ablation, TACE, and other local region therapy. There are some studies that have shown addition of SBRT and TACE together, and but there we don't have any randomized control data to compare directly. There has been a debate about RFA is good, SBRT is good. So they have their own advantages and disadvantages. Advantages of RFA is we could perform it in a single procedure, and the greater cumulative level of the evidence for the method that exists for SBRT. And RFA for the tumors that those are less than 3 centimeter in size, they have shown survival outcomes compared to the surgical resection. What are the advantages there? Is a non-invasive modality, and we don't have to care about the location adjacent to the major vessels. So this is not the contraindication of SBRT. So this is the advantage related to SBRT versus RFA. And this meta-analysis, this systematic review and meta-analysis was published in 2020, and they look into the studies that was comparing RFA versus SBRT for liver mets and hepatocellular carcinoma. So what they reported that local control rate in this study was equivalent between RFA and SBRT for hepatocellular carcinoma. But local control rate was better for SBRT for the treatment of liver metastasis, 83 versus 60%. And the efficacy of the SBRT in this meta-analysis was better for the patient if it was 2 to 3 centimeter. But as the lesion was increasing in size, SBRT was better. So what about the larger tumor size? Is it good? So there, again, we have the evidence, and you could see that those regions who are more than 2 centimeter, SBRT was better in terms of local control compared to RFA. And yes, so the answer is yes. For the larger tumor, specifically like more than 2, in some literature it is quoted at more than 3 centimeter. So SBRT is better in terms of local control. So where have we have to consider SBRT for HCC? We have look into the BCLC staging system and other guidelines. So where could we consider SBRT? So those patients who are not eligible for resection, or like whose underlying liver function is not adequate, so they are the candidates of transplant. So we could consider those patients as a bridging therapy for these tumors for SBRT along with other local regional therapy. So child pox A or B? Early B. So SBRT in selected cases do exist with other local regional therapy options. This was an interesting review that was published in 2021 that RF and SBRT for hepatocellular carcinoma, should they clash or reconcile? So again, we have a higher evidence for RFA, but it is affected by the location of the tumor. SBRT is less affected by the location, either whether it is nearby to the vessels or near the diaphragm. And better dose distribution for the larger tumors, more than 3 centimeter compared to RFA. RFA is not good for those tumors. And it's less invasive, it's invasive, but again, both require expertise of the radiation oncologist and also the other team members like medical physicist and radiation therapy technologist and the machine. So RFA depends upon the expertise of interventional radiologist. Okay. Am I clear till now?
Yes, Dr. Muneeb.
Okay. So going forward, okay. So SBRT liver with cirrhotic liver, I think I have mentioned about it that we do not consider child pox C patients for SBRT right now, unless we are considering a clinical trial, another setting. Usually it's child pox A or child pox B. And again, dose depends upon the underlying liver and the location of the tumor. SBRT followed by maintenance systemic therapy in improving PFS. Recently, this is the randomized control trial that was initially presented as an abstract in Astro in 2022 by Toronto Dr. Dawson, which is so she's the lady who has all the trials and studies related to liver radiation. So she's a radiation oncologist. We could go and see all the literature published. So this is the RTOG 11112 trial that was a randomized phase 3 study that compared the systemic therapy alone versus SBRT, followed by sorafenib in the hepatocellular carcinoma. And this was the inclusion criteria with a good performance status, child pool A, intermediate BCLC, and the SBRT dose was, again, it depended upon the location of the tumor, underlying liver disease, and mean liver doses on at the time of the planning. So it was not a fixed dose. And primary endpoint was overall survival, and the secondary endpoint was PFS and tumor progression free and adverse events. So as I mentioned, that prescription dose was varied from 27.5 to 55 fractions, and this was present in the Astro 2024 in a session, and this paper was published earlier this month, and it showed that the overall survival was better in SBRT and sorafenib group, 15.8 months versus 12.3 months, and time to progression was also better in SBRT and sorafenib group was 18.5 months versus 9.5 months in sorafenib. The important point in this is that 74% of the patient were with macrovascular invasion. So this is an important thing. And if you look into the sum of the diameters, that if we include all the tumors treated, they include up to 7.8 centimeter in maximum dimension. And 62% were multifocal. So again, size is not an absolute criteria for selecting patients for liver SBRT. It's the remaining liver volume we have to consider. And even in the multivariable analysis, SBRT and sorafenib group was better compared to sorafenib alone. Yes, the same. PFS was better again, and so now this is the first randomized control data we have that growing SBRT experience. The HCC is relatively radiotherapy sensitive with high sustained local control up to 90%. And even as per this randomized control trial, HCC with vascular invasion radiotherapy could be very effective, particularly effective. Basically. So what does Astro say in the guidelines for the clinical indication? So for the patient with liver confined HCC who are not candidates for curative options, surgery or thermal ablation, so it's an option, as I mentioned in my initial slides. And for those patients, dose escalated ultra or moderately hypofractionated EBRT is recommended with this period. So it's an option, as I mentioned. Okay, so the other learning objective is role of SBRT before surgical resection or liver transplantation. We don't have randomized control data for that. This is the thing which I mentioned, which is known as PVTT, portal vein tumor thrombosis. These tumors are usually carry poor prognosis because they have they are associated with more aggressive tumor phenotype, portal hypertension, and less functional liver reserve. And this could lead to portal venous increased pressure, resulting in ascites, hepatic encephalopathy, liver failure, esophageal varices, and invasion of the surrounding liver parenchyma. So it's usually as per BCLC stage, so it carries poor prognosis, and RFA usually is not very helpful in that. So this was a study that was published in 2019. Again, the most of the data either comes from Japan. They have widely published studies for treating. They have a very good experience, even with the particle therapy. They have many studies. So they have a very good experience for that. So they reported they offered preoperative radiation therapy of 18 grain 6 fractions before surgery or versus upfront surgery for those patients with PVTT. What they reported that patients who underwent surgical resection with no preoperative therapy had overall survival 1 year was 43% versus 70% with preoperative radiation. So again, in the absence of the guidelines, we need to come with an expert opinion, and we need to discuss the cases in the tumor board and decide patient-based. We have to take patient-based decision, personalized decision, that which modality is better for the patient, because sometimes patients are waiting for transplant. Their liver function reserve is not adequate, and they need transplant for the good liver function. So if they are waiting for the transplant, we need to offer them some local region therapy. If they are not candidate for RFA, so we have to think about TACE or SBR if we have the expertise available in our center. So we have to discuss cases in the tumor board. It's not the straightforward answer for that. But still, we have some studies that do support the role of radiation therapy before surgery, but we don't have any randomized control data. I'm not aware of that. Okay. So the other learning objective is there any role for monitoring liver function and tumor response using serum biomarkers, AFP and CA19-9? We will be discussing about the follow-up of the SBRT of the liver lesion because it's quite, it's not straightforward. We have to discuss. But again, CA19, AFP, yes, monitoring liver function, tumor response using serum biomarkers, it can play a significant role after SBRT. It's mainly primary liver cancer characteristic. So we have to monitor those. Yes. The other option is feasibility and outcomes of combining SBRT with systemic therapies, including chemotherapy and targeted agents. So there are studies and trials going on right now, but we do not offer concurrent right now for the SBRT patients. This is a paper that was published in Advances in Radiation Oncology in 2022, and there's they have given the recommendations that when we have to stop radiation, if the patient has been on some systemic targeted therapy or systemic therapy like VEGF, EGFR, ALK, BRAF, immunotherapy, so we have to suspend radiation. So they have their recommendations. So usually our policy is at McGill that we usually stop 5 to 7 days before radiation, and patient has to resume the systemic treatment 5 to 7 days after radiation therapy. In terms of hepatocellular carcinoma, combining immunotherapy, trials are going on. I will show in upcoming slides. Okay, so I think we have covered the literature related to learning objectives related to hepatocellular carcinoma, and we know that we don't have any randomized control data other than RTUG 1112. And recently, there was also a trial published in this month. Basically, the Japanese data, I think, they compared RFA versus SBRT. That was a randomized control trial, but that's not a straightforward answer. So to summarize this, SBRT is a good option as a local regional therapy, and we have to discuss cases in the tumor board, and we have to look into not the number of the lesion, it's mainly the normal functional liver that we can spare from the radiation treatment. We have to look into that part. Again, the more smaller the size, the more local control is, but up 3 to 5 centimeter radiation therapy has a very good control. When the lesion crosses 5 centimeter, the local control rate drops from 90 to up to 70 to 80%. Okay. So now the second part is metastasis. We know that 40% of the patient have metastasis of the colorectal cancer and other sites, lung, breast, and other melanoma, other metastasis. So identify candidates for SBRT based on primary tumor histology, disease volume, strategies for oligometastatic liver disease, use of SBRT alone, combination of systemic therapy. I think I have mentioned about the combination of systemic therapy part, that we don't give concurrent right now. We usually stop it before and after radiation. And the importance of limiting the number of lesions with good fear. Yes, and the efficacy of SBRT for anatomically complex lesions. For SBRT, usually we don't have a problem for the location. Yes, our dose depends upon the underlying liver function, also the medial side of the tumor, which are close to the stomach and duodenum or kidney. Then we have to drop down our doses according to the OARs. So what is the oligometastasis? So this term was coined in 1995, and it could be limited to the number, location, and based on the state of the limited metastatic capacity. There's a very good paper in the Lancet that was published in 2020, and they have given a questionnaire. We have to look into this questionnaire before deciding whether the patient has oligometastasis. Is it upfront genuine oligometastatic disease, like patient presents with oligometastasis, or is It's an induced state of metastatic disease. What is induced state of metastatic disease? Like if a patient presents with stage 4 disease and patient receives systemic treatment and the patient responds very well with the treatment, and then only one, and after the multiple repeated systemic stain, we find only one lesion that's progressing. So there are multiple terms like oligoprogressive, oligometastatic disease. So in those scenarios, we have to think the patient was polymetastatic disease, but because of the systemic therapy and treatment, the patient becomes patient showed very good response to the tumor disease, and then now patient has only one metastatic disease that's active. So this is a very good paper. We have to ask our question and decide treatment accordingly. In general, usually a patient who has a good performance status, limited metastatic burden, we don't have any adequate number. Some people say less than 5 metastases, 3 metastases, but there's not a number game. Every patient is different. And again, the most important part in the liver is what is the remaining volume of the liver and what's the functional capacity of the liver. The role of SBRT in management of liver metastasis from the colorectal and non-colorectal cancers, and advantage SBRT over traditional local therapies, and treatment outcomes including local control, survival outcome, and toxicity profiles. Like HCC, we can see that the number of literature for SBRT and oligometastasis liver, we could see that they started to increase in later in after 2010, and then still we are seeing many phase 1 and 2 studies and now phase 3 trial. Historically, radiotherapy primarily reserved for palliation only. The problem was the concern for toxicity and radiation-induced liver disease, as we mentioned. And the partial liver, now with the slowly, we could see that if we recognition that partial liver volumes could tolerate higher doses of radiation and expand the use of liver, that has expanded the use of liver radiation therapy. So there are multiple phase 1, phase 2 study, like PMH uses 6 fractions of radiation. Stanford uses single fraction, 3 fractions. So now we have multiple doses schedule, 5 fraction, 3 fraction schedule. So this was the study, and they reported that outcomes of 515 patients with 668 metastasis, and most of the metastasis came from the colorectal primary. So overall local control with SBRT was 87%, and with the grade 3 plus toxicities, almost 4%, 3.9%. So the low control of the radiation therapy was good. Implication of histology specific differences in radio sensitivity, yes, and predictive factors such as BD. So BD, I have mentioned that we tend to offer BD more than 100, or if you are not able to offer 100, at least between 80 to 100. So this was a study published in a Red Journal, and that showed that colorectal metastasis, you see, if you look at it, the dashed line here, this one. So you could see that, and the dark is non-colorectal. So colorectal liver metastasis are slightly resistant. So and melanoma and RC liver metastasis, 48 grade 3 fractions, BD up to more than 120, local control at more than 90%. So they also reported their outcomes in terms of location, lung metastasis compared to the liver metastasis. So even in the liver, the metastasis showed compared to lung, not a very good control. This was published from PMH group and in Red Journal, and they reported their outcomes. This was a meta-analysis of 13 studies with 490 primary liver cancer and 290 metastasis. And we could see that compared to primary HCC or cholangiocarcinoma, the local control rate was slightly less than the primary HCC with SBRT, but they further elaborated the doses, that those metastases that received dose BED less than 100 gray, and those metastases that received the dark line more than 100 gray. So they have a good local control if we offer, if the patient got treated with the doses that offered BED more than 100 gray. So that's what we have to offer. We have to consider, if possible, that at least BED more than 100 ablative doses, really ablative doses, if you want to achieve a good local control. And this was also published this year. This was a prospective multi-center study on SBRT, and they included not more than 5 lesions. They liver function, they took a normal liver volume more than 100 cc. We will be discussing about this part in our second session of SBRT, when we will discussing about the practical aspects of SBRT and the normal liver functions. And interestingly, they offered 60 grain 30 fraction, which is quite a higher dose. We don't offer that here. And the 45 grain 3 fraction with the BD 10 more than 100. And then they stratified lesion more than 3 centimeter but less than 5 centimeter, and then decided to dose up based upon their distance from the OAR. And for those lesions which were between 5 to 7 centimeter, they offered 50 gray in 5 fractions with BD 100, regardless of the distance of the OAR. That's the most commonly used regimen for the SBRT, 50 gray in 5 fractions or 45 to 48 gray in 3 fractions. Both have a BD more than 100. So they reported that, if you look into the graph, I'm not sure if it's visible to all of you, but the blue line is less than 5 centimeter, and the green is more than 5 centimeter. So we could see that PFS for those who have less than 5 centimeter was better compared to lesions which are more than 5 centimeter. And this one is also in terms of BED. So blue one is BED less than 100, and green one is BED more than 100. Okay. So based on the size, their local control rate was at 2 years more than 80%, and almost close to 78.4%, 48 months. And those tumors had more than 5 centimeter, was their local control rate was lower than compared to less than 5 centimeter. Okay, so we go for the. So this is the overall summary, and we have to see the good performance status, good liver function, control primary tumor, and usually now this is we have to consider free liver volume we can spare for the patients. So I know we are out of time, so I'll just summarizing the data. So we have a good evidence to support the use of SBRT as local therapy for liver metastasis when surgery is not suitable, and lack of phase 3 data to challenge the standard of care. So in that case, we need the MBT recommendations. And these are the recent ongoing NRG trials. They're comparing radiation therapy with protons versus photons. And the other is SBRT and TACE plus SBRT. Is also phase 3 trials. They're recruiting patients right now in Canada. And regarding the immunotherapy and other targeted treatments, so these are all studies that are still going on phase 1, phase 2 trials. They're open for recruitment, and this was shown in Astro this year. Again, yeah, this is also immunotherapy part. And these are some trials to reduce the liver toxicity. Okay, so quickly, only I have 3 slides for this. Indication of SBRT in intrahepatic cholangiocarcinoma and role of SBRT in definitive and adjuvant setting for ICC. So this was the systematic review that was published. We have a very, very limited data for SBRT in case of intrahepatic cholangiocarcinoma. So only we have to consider in selected patients as per the MDT recommendation, and those patients who are not candidates for the surgery and other standard of care treatment. So there are phase 1, phase 2 studies. We have the limited evidence. There are some retrospective in nature, and people have offered the SBRT to those. Again, the local control rate is good, but despite the evidence to support the SBRT as an option, even in the HCC. So in ICC, very limited evidence for SBRT, and dose and data for SBRT often extrapolated from HCC literature. And we have discussed about this RTOG 1112, and many prospective immunosuppressors are going on. So this is my last slide. So these are the 3 lesions. If you look into the location, if the patient comes with this lesion, so what will you be treating with? RFA, surgery, or SBRT? So one could argue that this everything can be treated with SBRT, but we have to look into the evidence, and we have to discuss this case in tumor board and see the recommendation of the board. For example, just to let you know that this lesion on the medial, this patient was sent for the surgical resection because it was easy, and this for the surgeons thought that it would be best for the patient. And even for the SBRT for this lesion, if you look into this picture, you see this stomach quite is almost touching the liver. So we could not offer a really ablative dose if the lesion is really occupying over here. So we have to compromise on doses if the stomach is quite, because otherwise SBRT we could offer, it could lead to the perforation of the stomach and duodenum. So we have to be careful. For this lesion, this was sent to the RFA because the interventional could go there with the probes and ablate this tumor effectively. And it's also, in terms of size, was quite smaller. Okay, for this lesion was sent for SBRT because of the location. It's nearby to the vessels. It's a deep location. So it was easier, like surgeon and radiologist both were okay to go with SBRT. So the take-home message after all the discussion is that we have to discuss these cases in MDT, and because we have wide variety of treatment options available, like the surgery, transplant, hepatology, interventional radiology, radiation oncology, medical oncology, and in absence of the randomized control data, we have to take decision based upon the patient available expertise. Okay, so this was the first. We will be covering the practical aspect of SBRT in session 2. Thank you.
Thank you so much, Dr. Muneeb, for a very informative session, and most of the LOs that were pertinent to this have been covered. I had requested our worthy participants to ask for any questions and queries. So there's one query from Dr. Zainab Rifat. She's asking regarding the recommendation monitoring using more sensitive markers like PIVKA2 in hepatocellular carcinoma.
What's the marker? Can you repeat the question? Sorry.
PIVKA2, protein induced by vitamin K absence or
I don't
antagonist.
know about that. I don't know. I don't have any experience for that, to be honest. I don't think so. That is very, like, maybe advanced setting, advanced centers, but I don't know if it's available in all the centers. I don't think so.
Dr. Muneeb, we have another question from Dr. Zain Siddiqui from University of Pennsylvania. So he's inquiring regarding your experience for SBRT in hepatocellular carcinoma post transarterial radioembolization.
I have not seen till yet We have seen like minimal doses after TACE, yes, because one of the lesion which was we treated recently. I am working with Dr. Neil Kopak. He's the radiation oncologist who does liver SBRT here. So I could discuss with him because in my I have not done it because we have to be careful in these cases. Even with the taste, we have to look. We have to discuss with the radiologist and everything, and we had to make sure that because the overlap of the radiation field with the other treated area, it's quite crucial. So I could take this point. I don't have any experience with that, and it's not a common thing.
Dr. Zain, would you like to share some experience pertinent to this?
Yeah, thank you, Dr. Muneeb. I'm Zan Siddiqui. I'm a radiation oncologist at Penn State
As in,
in Hershey, Pennsylvania. Assalamu alaikum.
mhm.
I'm a junior faculty. I'm like my second year of practice. I trained in Kingston, Ontario, so not too far from where you are right now. And
We-
then when I was hired for this position, I worked with Laura Dawson for a bit.
okay.
So that's my experience. And
So
yeah,
did you
one thing
treat
I'd
with?
like to highlight is a lot of the experience, like a lot of the inclusion criteria for RTG 1112, the main randomized trial that you presented, was they excluded patients, I think, with past radioembolization. And
I
that's
think so.
another really good modality for treatment. I haven't treated post radioembolization in my practice, but with Laura Dawson, we did, and she just reduced the dose. So whatever the RTG 1112 constraint would be, she would reduce it by one factor. And it also depends where the tear was. So they would, just like you said, talk to the interventional radiologist, because most interventional radiologists don't do dosimetry like we do. So the dose is actually really unknown. It um, a lot of the time, and it's I think should be an active area of investigation, like you said.
Yes,
But
it's not a straightforward answer. Yeah.
exactly. The sorry, I'm a little sick right now. So the another comment I had was the people that really they sought out in RTOG 1112 were people who failed transarterial therapy and had big tumors. So our outcome should be much better in the smaller tumors or early portal vein thrombosis. And the trial closed early because systemic therapy option changed. So I think if the trial had actually accrued, you'd see even bigger OS benefits. So I think the evidence is really there. A lot of the times, the cases I'm seeing, so they didn't do really much SBRT for liver cancers, HCC, before I came. So I see people getting TACE like 4 times, 5 times the same lesion, keep failing. And the toxicities are quite high, can be quite high for TACE. Patients going to the ICU, having bleeds. So it's an exciting opportunity for our field, and thank you for sharing. And there is randomized trials that repeat TACE. There's an Italian trial, Comito et al., that repeat TACE does not have the same local control. The trial closed early because SBRT was much better. So I think thanks for highlighting this important modality and having me.
Thanks, Zen, for sharing your experience. Again, it's an emerging modality. We have literature coming up, and this was, I think, first randomized phase 3 trial by the NRG. And yeah, so I think I have been working with Dr. Kopak for the last 6 months, and so he treats a lot of liver metastasis plus HCC. So all of those cases are discussed in first MDT and then referred to us for. So yeah, MDT is crucial in these circumstances.
Thank you so much, Dr. Zain, for sharing a very pertinent point and your important feedback. We also have with us Dr. Nadeem Pervez, and thank you, sir, for joining this session. And we would like
you to share some comments or feedbacks regarding this session so far.
Okay, so I think Dr. Nadeem Parvez is mute. We also have a hepatobiliary surgeon with us, Dr. Humaid. Dr. Humaid, would you like to share some feedback?
Yeah, thank you very much. I would like to give some comments. In fact, I've been following this RT and use in HCC since 2022. I followed some lectures as CME sessions on ESMO, and it is definitely an area which we should explore. And again, my interest was in this area because the patients with intermediate and advanced HCC according to BCLC, we just tend to put them aside as far as any useful treatment for their outcomes. And I just wanted to know that the area of why I had so much interest in this was it targets radiation therapy can target the larger tumors and the ones near the vasculature, especially the ones with the vascular thrombosis. So and I just want to comment on Dr. Muneeb about BCLC. If you really want to study about BCLC, you need to look at how it's been developed. And if you look at the recent BCLC of 2022, which Dr. Muneeb has presented here, it actually gives space for multidisciplinary team meeting. It's the first time they said that it's more a local regional decision, and the people there in the regions can look at the case and decide. And if you study the BCLC properly, if you look down at the lower part, so now they've brought in the role of MDT. And I think that in Pakistan we need radiation oncologists to come forward and kind of own these patients with intermediate and advanced HCC. I remember about a year back, I sent a case. It was a large tumor, 10 cc. It was involving the diaphragm, right lobe. The AFP was 90,000, and I specifically sent it to Dr. Bilal. And I don't know if he remembers this. And I had the query about if we can give him the radiation therapy, radiation therapy for this tumor. The patient actually went towards TACE, and his AFP reduced to, I think it came from 90,000 to the range of 10,000, and he was alive about 5-6 months back. So, I think that in MDT, you can't just say that it has to be discussed in MDT. You need radiation oncologists to come forward and say, I'm willing to take on these cases. And that can only be done maybe in Pakistan to a trial, or someone if with an experienced Dr. Muneeb comes back and plans it. Because the main issue will be radiation-induced liver injury. And you need a certain number of cases to see how those are managed. And then you can have the confidence of going in with radiation therapy in these patients. I think that's the reason radiation was not done in the patient I sent. Again, I think that Dr. Nadeem Abbasi, sir, he's done a very good job of doing site-specific MDTs. And for these patients in HCC, maybe you need to start a MDT which specifically targets intermediate and advanced cases of HCC. When you follow MDTs, you'll probably see that I've attended a lot of MDTs of HBP. And these cases, they don't tend to be discussed so much because they're foreign sorafenib and this. They don't actually discuss the size, the vasculature. Once it's out of the BCLC criteria for resection, for TACE, they just put them on sorafenib. So maybe if radiation oncologists want to work in this area, they need to do a more specific MDT on intermediate and advanced HCC, and then they have to be more vocal in the MDTs that we want to take these patients. Perhaps there can be a trial started in Pakistan, And because we have a lot of these patients which are just put towards sorafenib, and the outcomes are obviously dismal. The aim should be to bridge them towards transplant, because that is the definitive treatment. And definitely for the central lesions, the one with the vasculature involvement, the sizes, the large sizes, I think that radiation therapy does have a role, but it has to be more specific too, so that these patients can be easily selected. There has to be a better experience of this, and the radiation oncologists should be ready to come forward and say, okay, I'm willing to treat them. So this is my take on this. It was a very nice presentation. I'm very interested in this area because I think it brings in hope for patients with intermediate and advanced HCC. Thank you for allowing me to comment.
Thank you so much, Dr. Humaid, for sharing your experience. May I please request Dr. Nadeem Parvez to share some feedback?
Thank you very much, Maria, for giving opportunity, and sorry for not replying early. Was a great actually initiative. I think Muneeb bring a very good topic, and Kipro bringing all those important topic which actually need to be addressed in our country. So I think it's a good initiative. I would say that it's in the early stages for this liver SBRT in our whole region, including in the Middle Eastern country as well. We are not, and actually in around the globe. But I would have one question from Muneeb, if he's around, can answer that. What kind of motion management used in your center, Muneeb? Do you use 4D CT or some abdominal compression, or there's some other method like fiducial marker and treating on cyber knife? So what type of motion management you use for these patients?
Thank you, Nadeem. As per in our center, we usually use 4D CT for every patient. We use MRI at the time of the simulation. We have our dedicated MRI in our department so we do the CT scan as per the liver protocol, and we do the MRI at the same time if we do not have the diagnostic found, and we do the 4D CT for the patient, and we have abdominal compression belt. So sometimes we usually do one scan with the compression belt and one without it, and compare the liver movement. And regarding as far as the fiducial is concerned, so like liver SBRT, they have been doing for many years now, and it's the learning curve. Before the COVID, they used to put fiducials in every patient, and because during the COVID pandemic, so they were not able to send patient because of the delays in appointment. So the center started doing SBRT without the fiducial, but again, it's a learning curve. We do on Linux. We don't do on CyberKnife, because for the CyberKnife, we definitely need fiducials. So I will be discussing this aspect more in detail in the second part, the technical aspect. So I hope this answers your question.
Yes, okay. So I'll leave it for the next talk. Be very interesting to know the details about it. Thank you. And Dr. Bilal have the question which is coming in my mind as well, to use breath hold for this or not. And that's it from me. Thank you.
We don't use that.
अच्छा अस्सलाम वालेकुम मेरी थोड़ी आवाज खराब है very sorry got a very bitter very bad cold but congratulations to all colleagues actually a lot of learning today so please convey it to all thank you jazakallah khair for this very very important talk this is the beginning of an international MDT inshallah.
I will discuss that part about the breath hold in the upcoming session, but right now we are not doing that.
Dr. Bilal, thank you so much for your question. Thank you for all the participants for active participation and worthy comments. Dr. Bilal, would you like to conclude the session?
Thank you, Tuba. And thank you, Muneeb, for the discussion regarding the literature and indications and other local treatment options. I'm glad to have Dr. Muneeb and Zain, Dr. Nadeem Parvez, and everyone here. So we're really looking forward to the practical aspects of treatment planning and delivery. So thank you.
Thank you, Dr. Bilal. Thank you so much, Dr. Muneeb. And that's all from our side. We are concluding the session. Thank you, everyone.
Thank you very much. Allah Hafiz.